Okay, thank you very much, Eric, for a very nice, comprehensive talk. Dr. Ayman with us, so he will start the panel discussion. So over to you, Ayman.
Thank you very much. All the wonderful presentations. We have a lot of questions, and I know a lot of people interested in the information that you graciously give everybody. So I'm going to start with Dr. Diva. What is the role of octreotide in treatment of hyperinsulinism if diazoxide is not available?
That's an excellent question. And the reality is that around the world, it's very frequent that diazoxide, unfortunately, is not available. And in those countries, somatostatin analogs, particularly octreotide, is used as the first line of therapy. Obviously, in the United States, the situation is a little different, so we have the luxury of making other choices. Octreotide as the therapy of hyperinsulinism, the effectiveness is suboptimal too. In a series of neonates with congenital hyperinsulinism that were treated with octreotide, they found that the need for surgery was avoided only in about 30%. The major concern that we had with the use of octreotide is that there is some association with necrotizing enterocolitis, because that octreotide has the potential for decreasing blood flow in the splenic blood supply. So we recommend that extreme caution is exercised when considering octreotide for treating of these babies, and that babies that have other risk factors, for example, premature babies or babies with other risk factors for necrotizing enterocolitis, that you avoid the use of octreotide. At our institution, we limit it to babies that are older than 8 weeks of age because of this concern. So I would say concerns about effectiveness and concerns about side effects limit its use.
Correct. Thank you very much. Dr. Andrew, in nephrocalcinosis and osteopenia with borderline calcium and elevated PTH, do you advise to give calcium supplements, and what's the rationale?
That's an excellent question. I think to really know whether, what the cause of the nephrocalcinosis would be, I think is the most critical piece of that. So if that was a product of, phosphorus deficiency, which could have caused that, or was it related more towards medication effects? More commonly, in my experience, it's usually a product of loop diuretics, which then will induce a decrease or an increase in urinary calcium loss and an increase in PTH. So it's a balance where you need to give a little additional calcium to reverse the metabolic derangement of an elevated parathyroid hormone. So in that case, I would give a little bit of calcium with the goal of really trying, if at all possible, to maintain a calcium to phos ratio of 2 to 1.
Very good. Thank you. Dr. Eric, question, I think it's for you, or anybody can answer this also if you like. When should we
Yeah, Dr. Ayman, I think you froze on us here, at least on my computer.
Yeah.
Ayman, or you free?
No, you free.
Okay, I'll repeat the question. Yeah. Sorry about that. When should we ask for neuroimaging in persistent hypoglycemia, and what kind of neuroimaging would you like to recommend?
No, that's a good question. I actually don't think that neuroimaging is necessary for any baby who's got transient hypoglycemia. I think Dr. Diva can comment on the neuroimaging for babies with congenital hyperinsulinism, which is very different because those babies do have several more severe and more episodes of hypoglycemia. But I think that standard neuroimaging for a baby who's had hypoglycemia over the first 72 hours isn't necessary. I think if you were to do it, it would certainly be an MRI. But I think that would not be indicated. Babies, in the past, there's been some evidence that babies with severe hypoglycemia have injury in the occipital lobes. But I think that with our treatment and particularly screening of babies, that sort of brain injury should be much, much rarer. I don't know if either you want to comment on neuroimaging in the babies who've clearly got prolonged hyperinsulinism.
Yeah, I absolutely agree about the transient, and I would say that it's also limited in babies with persistent hypoglycemia due to hyperinsulinism, because we don't have any evidence of how findings in the neonatal period translate into later outcomes. So we reserve the use of neuroimaging for babies that have clinical indication of severe brain damage. Otherwise, we don't routinely do neuroimaging, and as Dr. Eric mentioned, will be a brain MRI. So one has to outweigh, the benefits of getting findings that don't necessarily translate into later outcomes with performing the test.
Okay, great. And also for Dr. Diva, how early in hyperinsulinism we should start investigating?
So I think for neonates that have persistent hypoglycemia beyond that period of the first few days of life, and the most recent evidence for New Zealand suggests that the period of transitional hypoglycemia or transitional glucose homeostasis adaptation is for about 4 days. So for babies that have persistent hypoglycemia beyond that point, investigation should be initiated to make the diagnosis. And then in the babies that clearly have a history of perinatal stress, I don't think that additional evaluation with genetic testing is necessary. But for those that the clinical history suggests a permanent form of hyperinsulinism, then genetic testing, as I mentioned, will be very helpful to identify those that may have focal hyperinsulinism. So the objective really is to identify that group, because that group can be cured. And the role should be to image them with a specialized 18-fluorodopa PET scan to direct them for curative surgery.
Okay, great. And this will take us actually to a question to Eric. What is the exact definition of transient hypoglycemia? I think you mentioned this in the presentation, but
yeah, well, I think that all babies after birth have a period of transient hypoglycemia when you look at sort of normal values for glucose in infants beyond the first 24 hours. But I think that in general, the definition is glucose value of less than 2.6 millimoles in the first 24 hours after birth. And I think that's why it's so important to be screening babies who are at risk. But there is no recommendation to screen all babies, because in most settings, breastfeeding will allow the normal transition of the glucose homeostasis. And so it really is just the at-risk babies that should be screened. There was one study from the US state of Arkansas where they did have a practice of screening all babies, regardless of risk factors for hypoglycemia. And they did discover some babies that you wouldn't have expected to be hypoglycemic. And they were able to correlate values of glucose below around 40 with later school performance. I didn't show that data because it's a complicated study, but I think that there's really, I think, more to come on this as to whether we should be more aggressive in maintaining blood sugars more than 2.6 millimole.
Great. Thank you very much. And this is a practical question for Dr. Andrew. In very low birth weight babies on TPN, sometimes they have a high calcium level on a minimal intake on calcium in the TPN. How should we manage those babies?
Yes, so I mean, I think that's a difficult one. So typically, I think it's always important in terms of what is defined as a high calcium, because first of all, the reference range for neonates is much greater than older children. So we'll take an example of somewhere around up to an ionized calcium of about 1.5 millimoles, or a total calcium of 11.3 milligrams per deciliter. So, I mean, that's certainly a little bit higher than what we're used to. So in those instances, I kind of go through, are there medications, again, that could be increasing calcium, things like thiazide diuretics, which are a little bit more bone protective. And then I need to look at the ratio of calcium to phosphorus, because if the phosphorus is still very low, that is going to be inducing the active form of vitamin D and may actually be contributing to that increased value of serum calcium. So I kind of look at the whole picture there and make sure that the ratio of calcium to phosphorus in TPN, I didn't have a chance to mention, at least in ours, is roughly 1.7 or 1.8 to 1 compared to the enteral feed. So I look at the ratios to make sure those are within reason, and then also look at the medications before considering other changes.
Great. And this will take us to another question, is how useful is vitamin D level in preterm and very low birth weight babies?
So I believe I shared something related to this. I think it depends on the way that the unit supplements for enterally fed infants. In our experience, given all enterally fed infants are going to be receiving vitamin D at 10 micrograms per day on average, plus what's in their feeds, we have a very low rate of vitamin D deficiency in our unit. And the majority of those patients have risk factors, medications that can increase the catabolic effects on vitamin D, those that affect malabsorption. And by and large, I don't think it's a huge issue. In fact, it's one of the few medications or supplements that we don't really do a great job of weight-based dosing, which raises another question. So by and large, I think it's a calcium and phos problem, not a vitamin D problem.
Okay, great. Thank you. Dr. Junaid?
Yeah, I have a few questions just received. So start with Andrew. What is the role of multivitamin in addition to vitamin D? Because in here or many other places, the vitamin D they are giving to all premature babies, but some centers here in UAE or outside using the multivitamins also. What is your experience, or anybody can comment of expert panel?
No, I think it's a good question, because I think if we look at some of the community hospitals that I also provide consultation to, we do see some practice like that, where some individuals will be giving a little bit less vitamin D in terms of the supplement, but also providing the multivitamin. And my main concern for those patients would be that we actually would be giving too much vitamin D if we provide both a multivitamin as well as a vitamin D supplement, because typically you're going to see potential for vitamin D intoxication, hypercalcemia, hypercalciuria, if you give over 20 or 25 micrograms of vitamin D plus the enteral feed. So that can be a real challenge. So I think you can do both, especially for extra iron, but you have to be careful to not induce intoxication.
Okay, very good. Eric, there's a question about the dextrose gel. Is there any delay in the treatment? Because what is the pharmacokinetic of dextrose gel? So if a baby has 2.6, 2.4, 2.2 glucose and you give the gel, the effect as compared to the IV, how you comment on that? They want to know the pharmacokinetics of that.
Yeah, so my understanding is that it's because it's rubbed right into the buccal mucosa, it's very rapidly absorbed. But it's different, obviously, than an IV dextrose bolus, in that the glucose will probably rise at a slower rate and not go quite as high. And I think that may be one of the potential advantages, is that you're avoiding these large swings of blood glucose using the dextrose gel, but it's very rapidly absorbed. And that's one of the reasons why people wanted to investigate it, was because of its ease of use and its rapid absorption and resulting increase in blood sugar. Because remember, these products are used for diabetic patients who become hypoglycemic, and they do that was their original use. And so they have a very rapid effect on blood sugar levels.
Okay. So there's one question for Dr. DeLeon. It's like a trivial question to me, that if a baby with HIE with associated hypoglycemia, how can we define if the abnormal neurodevelopment is due to the hypoglycemia or HIE?
Yeah, as Dr. Eric mentioned, you cannot.
Yeah.
And I think the key message that I would want to discuss is that, you know, those babies already have a high risk if they had HIE. You don't want to add the rest of untreated hypoglycemia, because there is some evidence, one study in particular a long time ago, that demonstrated that babies with HIE and hypoglycemia had worse outcomes than those with only HIE without hypoglycemia. So I think it's impossible to define what resulted in the brain damage. So, but you do want to prevent what you can prevent, and that would be correction of the hypoglycemia.
Okay, so Eamon, do you have any more?
Yeah, I have two more questions to Dr. Andrew. Is the same. First, talking about 45 babies on 45 milk, and they're receiving supplements, vitamin D, 400 international units. Are they at risk of having too much vitamin D or vitamin D intoxication?
Absolutely. And actually, in consultation with our dietitians, our teams will often stop the extra vitamin D in those particular patients. For those that maybe are receiving a multivitamin, they would at least maybe cut the amount in half. But yes, they are certainly at risk for vitamin A and vitamin D intoxication.
Okay, and another question, how often should we do calcium and phosphorus level when baby receiving caffeine or phenobarbital?
So typically the screening should begin around 4 to 6 weeks of age. If the risks remain, I think you need to consider repeat screening for someone that maybe doesn't reach our respective thresholds roughly every 2 weeks. Or if your level of concerns on the lower side, you could potentially push that to every, closer to 4 weeks. But I usually think 2 to 4 weeks is a good reference range for screening frequency for at-risk infants.
Great, thank you very much. We have a lot more questions, but I think we are out of time. So I would like to thank everybody for their participation. Eric, it's always a pleasure to meet you and see you again, even virtually.
Yeah.
I'm looking forward to Philadelphia Eagles winning the game tomorrow or tonight. And I will, hopefully you will stop by when I come to Philadelphia next time.
Yeah.
Thank you very much. Appreciate your coming, and have a good day and good night for people who are watching us in Australia. Good night.
Okay, so thank you very much, all the three speakers, and Eamon. We still have a little bit left of our program. So I have some announcement. We have a workshop on the nutrition in the NICU, optimal use of exclusive human milk diet, and it's really interesting. We will start at 17:45, so like 20 minutes from now. And later this evening, 18:30, we will start our cardiology session, which is the last session of the day. Again, I remind all the participants to interact as much as possible, and you have a chance to win a smartwatch. So, inshallah, within 20-25 minutes, we will meet you again on exclusive human milk diet, optimal use of exclusive human milk diet. We have very good speakers on that. So nutrition in the NICU, we will talk about that. So we have now 20-25 minutes break.